Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Saramelli, and I oversee Grand Rounds for our department. I wanted to say just a couple of things about the Grand Round series before I turn it over to Jurgen to introduce today's speakers. First is, please write any comments or questions into the chat or the Q&A. Either one works. I can keep track of those and go through any questions with the presenters at the end. There is a group of us that works on Grand Rounds throughout the academic year, including Semhar. And Charles, when we had tried out the hybrid event at Harborview, I have Mike Walker's name here, who had worked on IT for Grand Rounds. Mike has taken a new position outside of the department and is no longer working on the Grand Round series. Brandon is here today, working on that with us, and may be doing that for at least the short-term future. There's several sources of funding for Grand Rounds for this academic year, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. I think that's all about the Grand Round series, and I want to say just one comment about today's presentation here on the crisis system integration and improvement opportunities and challenges. This is a joint presentation with Dr. Mark Snowden and Dr. Matthew Goldman, who Jurgen will say more about, talking about the crisis response improvement strategy occurring here in King County. And with that, I'll stop and turn it over to Jurgen.
Well, yeah, thank you, Joe. And thanks to all of you for joining today. And before I turn it over to our two presenters for today, I want to just take a minute to introduce them. I'm going to start with our first speaker, and that is Dr. Mark Snowden. Mark really needs no introduction to this group. He's a tenured professor and a vice chair in our department. He has served as the chief of psychiatry at Harborview Medical Center for more than a decade. He's also co-chairs our department's EDI Council. Just a few comments. Mark is a wonderful colleague and a gifted leader whose wisdom and integrity and judgment I've come to trust and rely on probably more times than I can count. He trained here at UW. He's trained as a psychiatrist, as a geriatric psychiatrist, and a health services researcher. He's led a research team that has helped implement a whole bunch of interesting programs, including the PEARLS program, which is an evidence-based model of depression treatment for older adults across the country. And over the past few years, he's provided really great leadership, not only here at Harborview, but also on the Washington State Crisis Response Improvement Strategy Steering Committee, also called the CRIS Committee. And that's a group that's been working together across the state to improve mental health crisis response around our state. And you'll hear a little bit more about that work from Mark in a minute. And then following Mark, we will hear from Dr. Matthew Goldman. Dr. Goldman is a psychiatrist and a physician scientist who just recently joined us here in Seattle from San Francisco, and he is a clinical assistant professor in our department. Dr. Goldman sees patients here at the PES at Harborview at our county hospital, but his day job is the fact that he is the medical director for the King County Crisis Care Initiative. This is a relatively new thing. It's a voter-approved levy that's going to invest over $1 billion here in our community in 5 crisis centers, in some new residential treatment capacity, and some workforce development programs across King County over the next 5 years. And before he joined us here in Seattle, Dr. Goldman was the medical director of comprehensive crisis services in the San Francisco Department of Public Health. He holds a number of leadership roles in national organizations that are focused on mental health and addiction services. He conducts grant-funded research on crisis service and suicide prevention in several states. And he co-chairs the policy advisory group for the Journal Psychiatric Services. Does a lot of other very cool things, and maybe we'll hear some of those from him. But with that introduction, I want to thank both of you, and I want to welcome you to our Grand Rounds today.
Thank you, Jurgen. It's a pleasure to be here. And I too am glad that Matt is able to join. By way of overview, if I can get my slides to advance here.
Mark, I'm sorry to interrupt. We're seeing the presenter mode rather than just the one slide at a time.
How about now?
It's the same. Yeah, we see one slide and then the next slide in the notes section.
I swapped it out. So let me try loading it again. Is that better?
That's better. Thank you.
Okay. So by way of overview, I'm going to talk about the Washington State perspective on this and the work that I've been doing, as Jürgen mentioned, with the Crisis Response Improvement Strategy Committee. And then I'm going to turn it over to Matt to talk more specifically about the work that's happening here in King County. I like the picture of these skydivers because with the time limits that we've got, I'm really going to be focusing on the 10,000-foot overview and not being able to get into all the details. But I do hope that we have some time at the end for some questions. To set the stage, I think it's helpful to know a little bit about the way behavioral health services are organized across Washington State, because that has direct implications for how the work to transition and transform the crisis response system in the state is going to go. So for folks who don't know, the state is divided into 10 regions, and each region is served by a behavioral health administrative service organization, or BHASO. As you can see from the map, some BHASOs cover multiple counties, whereas some, like here in King County, have a single BHASO for the county. As you can imagine, an advantage of this system is that it does provide for local leadership and the ability to craft services to more local needs than might be done if everything were in fact centralized. Consequently, the downside of this approach is that it can lead to great variation in the types of services and numbers of resources that are available across the state. And certainly that is one of the things that we hear in the CRIS committee meetings, is that there is great variability in terms of what's available as you move to different parts of the state. The first year of our work was really designed to get a feel for where were we at baseline. And in the most oversimplified slide that I think I have ever made, I'm going to summarize a whole year's worth of work into one table with one row. And it shows you that statewide, we had 6 crisis line providers serving the entire state of Washington prior to the go live of 988. There were 41 mobile crisis teams that had been identified. There were 16 crisis stabilization providers who had access to 234 crisis stabilization beds. While all aspects of the state had access to crisis lines and at least some mobile crisis teams, there were 3 BHASOs that had no crisis stabilization providers or beds. Unless you think this is all just small places in rural parts of the state, by the definition being used, King County was in this group that had no crisis stabilization providers or beds at the time that this survey data was collected. Based on federal legislation that was passed back in 2020 and called for a due date for implementation on July 16th of 2022, we were called to move from the 10-digit number for the National Suicide Prevention Lifeline to a 988 system. That mirrors the 911 system used by EMS responders. In addition to the 988 number, the providers at the call centers were to have capabilities of having people access them via text and chat as well. It's easy to understand some of the rationale. 988 is a much easier number to remember. It starts to mirror thinking about behavioral health crises the way we think about medical crises in 911. And it also starts to move beyond thinking about the call center as just a place that interacts with a person over the phone line in a discrete event to as being part of an overall system of crisis response. On the national scene, the guidance for this was primarily done by the Substance Abuse and Mental Health Services Administration, or SAMHSA, which has funded the National Suicide Prevention Lifelines across the country. SAMHSA was certainly not the only group. Vibrant Emotional Health has played a significant role in helping to deal with some of the technology challenges as people change to the 988 system. There was clearly representation from NAMI, from the National Association of State Mental Health Providers, but I would say SAMHSA really took the lead, and a mantra started to develop that simplified what this was really all about. And the goal was to create someone to call, which is the 988 call center, someone to come, which would be a mobile crisis response team, and then a place to go. And that would be the crisis stabilization unit, as distinct from emergency departments and hospitals that were often the default. Here in Washington State, legislation was passed in House Bill 1477, that's often referred to as the 988 bill, that really did lay the framework and foundation, both fiscally and from a leadership standpoint, on how Washington was going to approach implementing this federal expectation. First and foremost, the bill included a telecom fee that shows up on your cell phone fees, comparable in principle to the way the 911 system is funded, though at a much smaller amount, so that when it was first passed, it was 24 cents per month per active line, and after the first year, that increased to 40 cents per month. Washington became one of only a handful of states that before the go-live date had actually identified a source of funding to deal with the expanded services that moving to a 988 system was in fact going to require. The bill also had the notion that we would transform the call centers from simply being a call line to a 988 hub. And I'll say more about what the hub definition would look like in a few slides. It also planned from the very beginning to establish what would in fact be the first in the nation of a 988 tribal line that was devoted for tribal members and operated by tribal members. It established the Crisis Response Improvement Strategy Committee as the central structure for building out the system, and was explicit about saying that persons with lived experience of behavioral health problems and crises needed to be active participants in the CRIS. There was a hope that we would reform, expand, and improve upon the system of next day appointments and make investments beyond the 1477 legislation to expand crisis teams. So at its core, there were three sort of committee structures created. At the heart was the CRIS committee, which was a 35-member group. 10 were appointed explicitly by the legislation, and the other 25 members were recruited and approved by the Healthcare Authority. The role of the CRIS was to advise the steering committee, which was also created by the legislation, in making actual recommendations that would go to the governor and to the legislature. In addition to steering committee and CRIS committees, there were 6 subcommittees defined in the original legislation, one dealing with tribal affairs, one dealing with credentialing and training issues, one on the technology needs, one specifically on cross-system collaboration between 911 and 988, one on confidential information because it was viewed that the crisis hubs would in fact keep information on callers. And then there was the 988 geolocation committee dealing with an aspect that I'll talk about momentarily. Upon the first meeting of the CRIS, it was determined that we needed 2 additional subcommittees. The first was for lived experience, because despite having 4 members with lived experience on the CRIS committee, we felt that we needed to have an ongoing mechanism where any person with lived experience could participate. And so a subcommittee was formed. Additionally, based on data and discussion about increased suicide rates for people living in rural and agricultural communities across the state, we created a rural and agricultural community subcommittee. The CRIS committee meets once a month. The steering committee tends to meet once every 2 to 3 months. By far, the lived experience subcommittee has been the most active, and they meet on a monthly basis. CRIS committee meetings tend to be about 3 hours. They start with an overview from the Department of Health and the Healthcare Authority to remind us in some ways that the CRIS is advisory and that the people still running the system will in fact be the Department of Health for the call centers and the Healthcare Authority for the other aspects of the crisis system. We tend to then move into a presentation of a person with lived experience sharing their actual experience with the crisis response system, oftentimes pointing out in really powerful ways the shortcomings and the failures of those systems. And the goal of that presentation is to keep everyone grounded in the fact that this is really not just a system and existential exercise, but is really designed to improve the experience that real people are having with what is often felt to be a broken system. The legislation also directed the Behavioral Health Institute at Harborview to facilitate the CRIS and steering committee processes. And that's how I came to be involved with the work, because the legislature required that there be a member on the steering committee from the BHI. Given the complexity and the time commitments that this work involved, Harborview subcontracted with Health Management Associates to support this work, and it is HMA that really does the day-to-day work of managing the processes, and we at the BHI meet on a weekly basis to collaborate with, to advise and support HMA in the process. One of the first things that was done as part of this work was to appoint a subgroup to talk about what is our overall vision, guiding principles for what we are trying to achieve. And what came out of that group is a vision that says 988, Washington's crisis response, would be building understanding, hope, and a path forward for those in need, where and when they need it. On the person-centered side, we were hoping to have timely access to high-quality service without barriers, to have a welcoming response that is healing, trauma-informed, and provides hope and ensures that people are safe, that it would remain person and family-centered care, and that care would be delivered responsive to the age, culture, gender, sexual orientation, disability, geographic location, and language needs of the people being served. On the system side, there was a clear intention that we ground the system in principles of equity and anti-racism, that we be centered in and informed by lived experience, that we would coordinate and collaborate across system and community partners, and it would be operated in a manner that honors the tribal government to government processes, that we would be empowered by technology that would be accessible to all, and that it would be financed sustainably and equitably. Looking specifically at the call center hubs ideas, the national best practice being developed is that call center hubs, in addition to dealing with crises and suicide assessments of people on a crisis line, would develop protocols for warm handoffs in collaboration between 911 and 988. That call centers would have the capability of dispatching mobile crisis teams directly to a person in need through GPS technology. That a call center would keep a registry of hospital psychiatric bed availability so that mobile crisis teams would know if a person needed to be transferred somewhere, where would there be an appropriate bed. And finally, call centers would be able to schedule follow-up for a person after the call and have an ability to monitor whether that follow-up in fact was kept. If you look at Washington State, by the time of the July 16th go live in 2022, we had consolidated down to essentially 3 call centers serving the entire state. Those here in the Seattle-King County area are probably most familiar with Crisis Connections, which serves King County, but Frontier Behavioral Health serves the northeast section of the state, and Volunteers of America serve the remaining parts of the state. By November of 2022, several months after the go live, we were able, in fact, to roll out the Native and Strong Lifeline. And if you call 988 in Washington State, you get the option of pressing 4, and that transfers you to the Native and Strong Lifeline, which is, again, a lifeline for all Indigenous people in Washington State. It serves both American Indian and Alaska Native populations, First Nations people, tribal members that are unenrolled descendants, and any tribal member regardless of the actual homeland of the tribe. Looking at data, there was about a 30% increase in call volumes between June and July of 2022 when go live occurred. That number has dipped a slight bit, but it's still over year-to-year call volumes that were experienced prior. I think it is a testament to the work and ingenuity of our call centers that they were able to increase their staff sufficiently to handle this increased volumes of calls in a relatively short amount of time. If you look at more recent data on where we are now with call volumes, in December, there were 6,732 calls that were answered across the state. About 1,900 text responses and about an equal number of chat calls. On the Native and Strong Lifeline, there were 448 calls. The standard set is that all calls need to be answered within 30 seconds, and if they're not answered in that time frame, they are bumped to a secondary provider, which in many cases would be a national suicide prevention lifeline that would be located outside of Washington State. Our numbers have remained quite high for both phone, text, and chat responses, but in efforts to improve our ability to keep calls in the state, the call centers have developed a backup coverage system amongst themselves, such that, for instance, in King County, if for some reason the Crisis Connection call center was not able to pick up the call, Volunteers of America has agreed that it would be the backup. And so as you see in this map, all areas of the state now have a backup call center so that before a call would get transferred out of state, it would need to not able to be responded to by the primary call center and the secondary call center. Challenges with the call centers are clearly recruiting and maintaining the workforce. And a lot of that deals with the salaries that they are able to pay people for doing the work. Clearly, coordination with 911 from the 911 perspective is sort of a new concept. And there is this period of getting to know each other and trust that people are able to do the work, the need to actually change some of the rules for how 911 works to make it crystal clear that it is appropriate for them to be transferring calls to 988. To further that work, there have been pilots now put in place where the state is placing people from a 988 call center actually in a 911 call center, so they get familiarity with the people in the center, with the types of calls and protocols that 911 is dealing with, to further the creation of protocols that would dictate when a call should be transferred from 911 to 988. The geolocation issue persists, and as you may know, if you call 911 through geolocation GPS technology, they are able to locate you so that responders can be sent should you become unresponsive and unable to tell them where you are. We don't have that capability with the call centers. To date, call centers truly have identified people only by their area code. And as we all now know, in the era of cell phones, the area code has little to do with where you are physically in space. And so the call centers are still waiting guidance from Vibrant Emotional Health to figure out what is the technology that we will use to have all call centers across the country be able to do geolocation. If I focus next on mobile crisis teams, as I said at the beginning, there were 41 mobile crisis teams across the state. Probably the most evidence-based form of this here in Washington is the Mobile Response and Stabilization Services for Youth, MRSS. In 2022, prior to 988 Go Live, there were 4 teams, and they served 5 out of the 39 counties of the state. By 2024, the state has been able to increase to 14 teams that serve almost half of the counties in the state. A more traditional view of mobile crisis would be first responders. And so the committee has spent a lot of time talking about what is the appropriate role for what I am calling traditional first responders, meaning fire, EMS, and police. There are a significant number of 911 calls that relate to behavioral health needs without, in fact, medical needs. Depending on where you are in the state, that is estimated to range from 10 to 50% of the 911 calls. There is consensus that first responders are not needed in many of those calls, but are in fact needed in some. And so the work is to define what is that small subset of calls that do require first responders. Clearly, when safety issues are concerned, there's this concept around rescue that says that the police will often need to be involved. Clearly, if there are medical issues, it's easy to understand why fire and EMS, emergency services, would be involved. Many times, the speed of the response that is needed often will dictate using traditional first responders, because in most instances, first responders have a time that is much shorter to the response than traditional mobile crisis outreach would have. And then lastly, we've had the experience through some changes or misunderstandings in legislation that make it clear that at times behavioral health providers, people like DCRs or medical providers, actually do in fact need to have police on the scene in order to do their work safely. For mobile crisis teams, the best practices that are being developed are that those teams need to have clinical people as part of the response team. In the more recent evidence-based programs, it is shown that peers should be part of those teams. They need to have GPS-enabled technology, and they need to operate on the notion of engaging the police really only when necessary. The committee spent a lot of time trying to figure out how to define that, and in fact, a work group was created to brainstorm what are our challenges, barriers, and fears, and develop recommendations on how to think about the appropriate role for police as first responders. I think this was the most challenging part of the work for the CRIS, and in some ways, I would say it is the greatest success. And I want to share some of the norms that that group created because I think it will serve us all well in other places where we work where things are really quite tense and difficult. The group clearly acknowledged that this is not really about if first responders and mobile crisis will collaborate, but how, because it is again a given that first responders are part of the system, whether we like it or not. We needed to accept that structural racism and oppression exist and has life-threatening impacts for people of color and marginalized communities. We had to make space for multiple perspectives and experience, and yet have the group keep focus on the task at hand. One of the most telling statements that they made is that we need to have the ability to critique a system while still acknowledging that good people work within the system, and to expect that the work would be difficult and at times uncomfortable. I won't go through all the barriers that the group committed, but I want to share some that deal with the fact that training and consistency of training in integrated care is needed, that we needed to define what actually the safety risk component and definition of need for rescue really needed to be. There were clearly concerns that there was lack of parity in funding between 988 and 911, and that needed to be addressed. At the end of the day, the group did come up with recommendations that talked about we needed leadership, mostly defined as the political will to continue the difficult discussions, that we had to have resources that would provide adequate funding, that we would have to have changes to policies to create explicit guidelines, and in particular, to have clients who are calling and using the system know what to expect. There are people from NAMI and others who actually at this point in time feel uncomfortable recommending that certain communities call 988 because they can't guarantee that there won't be police involvement when that is not necessary. As I mentioned, we needed to define the criteria for when rescue is truly needed, and we had to expand the training for both law enforcement and behavioral health co-responders. Lastly, once we have guidelines and procedures in place, there's a need to make sure that those are in fact being followed as desired. At the end of that work, we had several testimonies and quotes from people who served on this work group speaking to, in fact, what a good experience they actually had, despite the fact that this was very difficult work for them to do. And so again, I would highlight this as, in fact, one of the significant achievements of the CRIS work to date. With that, I'm going to stop and turn it over to Matt, who's going to talk about issues here in King County.
All right, thank you, Mark. Bear with me for a second as I share my slides. Okay. All right, are those looking okay? Great.
Yes.
Thank you. Well, thank you so much, Mark, for the presentation. That's a great framing for what I'm about to talk about, actually. First, just want to say hello. It's a pleasure to be here. As Jürgen mentioned, Unitzer, I'm new to the area and new to the department. I've really enjoyed working in psych emergency services at Harborview and getting to know many of the faculty in the department. And I'm also excited to get to share some of my day job with you all here to bring a little more about what's happening locally in King County, especially around crisis services, for all of your awareness and honestly ideas and potential future collaboration. So hope that this will be of interest. So as mentioned, I'm the medical director for the Crisis Care Centers Initiative. I'm a psychiatrist, I'm a health services researcher, and I've been working in crisis services for quite a few years at this point. And the levy opportunity here in King County is really quite an amazing thing. And to frame it in the same continuum that Mark described just a moment ago, in King County, we have someone to contact, we have someone to respond, but currently there's not somewhere safe to go. There's not that mental health substance use crisis facility that has that specialty where, day or night, rich or poor, no matter who you are, if you were in a crisis, the only place to go is really to an emergency room where I think many of you might be familiar with what can happen there. Certainly, people are trying to do their best, and in psych emergency services, there's a specialty service there. But in a lot of the emergency rooms, folks often spend a long time waiting for treatment, not necessarily getting the services that they're seeking, and that can be a much more challenging experience. And so we want to create a very welcoming and safe front door for people who are in a mental health or substance use related crisis to be able to readily access services. I'm also going to add a piece to this continuum, someone to follow up, and I'll share a little more about that later. But I do want to emphasize that crisis services as an access point are meant to be able to triage, to make an assessment, to provide a brief, intervention. So certainly there are clinical interventions that happen during the crisis experience itself, and there's an evidence base for many of those interventions. But there's also, crises relatively short-lived, and then somebody goes on living, and all of the factors that might have contributed to somebody's crisis experience won't necessarily have been resolved on such short order. And so having follow-up resources to then link people to the many evidence-based treatments that are going to be available in outpatient and other type settings is also a key focus of the initiative here in King County, and I think ideally crisis services more broadly. Just to frame the timeline, so where are we in this process, so that you can think as I'm describing what the initiative actually is, kind of where we are. So the first step, actually even before December 29th, the first thing that happened was that the voters of King County in April of last year approved this ballot measure that approved the Crisis Care Centers levy. This is a property tax levy, so it'll be funded by property taxes and raise over $1 billion to support the various activities that I'll describe here. The first step of the process was to create what's called an implementation plan. This is basically a high-level strategy and budget document that describes how those funds will be spent over the 9-year term of the levy from 2024 to 2032. And that implementation plan, which we worked on in the King County Department of Community and Human Services, went up through the executive's office, was transmitted to King County Council. And today, that plan is in front of King County Council for their consideration. They are reviewing it carefully. They are likely to propose amendments to the plan. And so it's currently in this political process to review it and ultimately approve it. And we anticipate that sometime this spring is when King County Council is going to finalize their approval. And that will then unlock our ability to have spending authority to actually utilize the funds that are being collected by the property tax. And once that happens, we are hitting the ground running. We're already doing early planning for implementation as soon as council passes the levy. And we're aiming for some early procurement activities. So meaning having sort of competitive procurement mechanisms like a request for proposals kind of thing to start to get the dollars out the door to fund the activities that are described in the implementation plan. These are the three purposes that were defined in that ordinance that King County voters approved. So this is basically what the people of King County told us as the county what we have to do. There are three main purposes. The first being crisis care centers. So this is to establish and operate a network of 5 crisis care centers across the county, including one that's dedicated to serving youth. And I'll share more about that clinical model in a little bit. A second is to restore historic levels of residential treatment. So residential treatment facilities in King County had declined quite a bit from about 350 down to it was something in the order of 240. And so there's a need to restore a lot of those beds. And then also with available funds to expand and build new beds for both mental health and potentially substance use treatment. And then the third component of the ordinance, which we call the supporting purpose 2, is to address the community behavioral health workforce shortages. Mark described that. I think we all feel that there's just not enough workers to go around to cover all of the clinical services that are being demanded and to meet the needs. And so there's a significant investment in workforce, and I'll share a little more about that as well. And so with these three purposes, we then initiated this process of developing the implementation plan that I described. To do that was an extensive process, and we really went deep on community engagement. This is not something that we did sort of in a vacuum off on the county side on our own. We did many interviews, including with a lot of people who have expertise in culturally and linguistically appropriate services, as well as youth providers. We presented broadly. We did field visits to 20 sites across the country, as well as locally and in-state. We held multiple community engagement meetings, and we also facilitated focus groups. And what all of that activity did was it helped us translate the ballot measure that said, here's what you have to do, into our specific strategies that are described in the implementation plan, which are sort of our proposal, our vision of how we are going to actually implement these many activities and utilize these funds in a way that meets the purposes as required by the ordinance. There are 8 of these strategies. The first 3 match the first 3 purposes. So crisis care centers is the first one, residential treatment capacity is the second, and the workforce is the third. We also included some additional strategies on early crisis response investments, which I'll share more about, capacity building and technical assistance, and then also sort of more administrative stuff like evaluation and performance, evaluation and performance measurement, crisis care centers, levy administration, and then reserves, which is just a fiscal mechanism. This gives you a sense of the investments in these different strategies. So the $626.8 million to operate these crisis care centers over 9 years is a substantial investment to be able to get that huge program off the ground. Also significant investments in residential treatment capacity, 173 million, 164 million or so invested into the workforce, and then also substantial amounts into those early crisis response investments, about 67.7 million. With the remainder balance going towards things like capacity building, technical assistance, evaluation, and general administrative costs. I'm going to share in a moment what the actual clinical model is. So what is a crisis care center? But I want to frame that by describing first some of the clinical best practices that are really important in crisis care centers. And this is partially reflective of a lot of that community engagement feedback that we got. We heard things about care needing to be trauma-informed, recovery-oriented, and person-centered. Those are all different concepts that really reflect the importance of meeting people where they're at and helping them meet their recovery goals in a way that's aligned with their needs. Culturally and linguistically appropriate services was a theme that came throughout, and I'll refer to that multiple times throughout describing the initiative. integrated care, so serving both mental health and substance use needs, as well as having some basic capacity for serving medical needs. We don't want there to be, strict entry criteria where, somebody comes in with a stubbed toe and we're turning them away to have to go to the ER. We want to be able to accommodate, a decent range of basic medical conditions, nothing that would require emergent medical care or extensive diagnostic workup or, IVs or anything like that. But we would want to be able to handle some needs in order to be able to, again, serve as many people as possible in this behavioral health specialty setting. And then also have this be a least restrictive setting. So wanting to keep care voluntary for as long as possible, working with somebody in order to meet their needs. Certainly if somebody does end up meeting involuntary criteria and otherwise is not engaged in care on a voluntary basis, then there is an ability for DCRs to evaluate somebody on site. But otherwise, trying to work with people to be able to serve them in a least restrictive setting. This is a crisis care center, a series of boxes and arrows for now, but eventually will become real buildings with real staff serving real people. The main components of a crisis care center are these dark blue boxes that go through the center of your screen. In the upper left corner, you see the 24/7 behavioral health urgent care. So this is the front door to the crisis care center. Anybody can walk in. At least everybody will get a assessment and triage, so a no wrong door type approach to be able to meet everybody's needs. There might be some people who are not appropriate for the setting if they're in any kind of significant medical duress or something else is happening where it's not a mental health or substance use related need. There might be people who end up not really benefiting from services there and could have transportation arranged for them to get to the right place. But in the urgent care itself, this is where there can be a screening, assessment, triage again. Medication refills is going to be a big focus of treatment here. Connecting people to prior services or even making referrals to new services for folks who would be safe and appropriate to remain in the community without needing facility-based care. And our understanding from similar models like in Arizona, where a lot of this work is done, is that as many as 80 or 90% of people who come in through urgent care are going to have their needs met in that urgent care setting and be able to leave from there. That said, there are going to be some folks who have much higher acuity needs. So, acute suicidality, behavioral distress, other things that might need more stabilization. And so that's where the 23-hour observation unit comes in. So folks might be triaged from urgent care into that unit. This is also a destination for first responder drop-off, and that would include emergency medical services, ambulances, law enforcement, both on voluntary or on an involuntary detention status, and also mobile crisis units. And so this is a destination point where people should really be able to access a full range of psychiatric care. It's not an emergency room where there's all medical services available, but in terms of the psychiatric care that's provided in a setting like the PES, this should be able to have a similar range of acuity that can be served. This is also, of course, an important triage point. So is somebody good to go? And our understanding, again, is many people will be benefited from a few hours there, but some might need a higher acuity setting. So again, a DCR could do an evaluation and facilitate a transport to an inpatient setting on an involuntary basis. People could also be voluntarily hospitalized from this setting. Or for those for whom 23 hours isn't enough, that's where the crisis stabilization unit comes in. So that's really meant to be almost a step down in acuity, where people who need more time, if not more acuity, so problem solving, substance use counseling, potentially withdrawal management supports, being able to benefit in that setting for up to 14 days is where the crisis stabilization unit comes in. The orange box at the bottom of your screen, I mentioned follow-up, and you can see all orange lines point to post-crisis follow-up. So this is a really important part of the model where regardless of where you're exiting the program, people are going to be able to access ongoing care coordination, peer support services with a strong emphasis on engagement and navigation to downstream services, and then also brief intervention. So while somebody's getting bridged to an additional provider, they might be able to help somebody get some initial intervention or get a med refill or other things within that program itself. And importantly, because of inequities that we see in how people are able to access care, especially along race ethnicity lines, this is going to have a strong focus on providers that have expertise in culturally and linguistically appropriate services to provide these post-crisis follow-up services. Finally, last but not least, is the Youth Crisis Care Center. Not to forget that all of the urgent cares and all 5 of the crisis care centers will serve youth, but there will be one of the centers that's dedicated to serving youth. If a young person comes into one of the other crisis care centers that's not the youth specific center, but who needs facility-based care, they could be transferred to the Youth Crisis Care Center. And then the Youth Crisis Care Center itself will have walk-in, first responder drop-off, and also have specialty units that will be able to serve young people who are in a mental health or substance use related crisis. I see we only have 9 minutes left, so I'm going to keep moving us quickly through this, just to say that there are 4 of these zones where the crisis care centers will be sited. So this gives you a sense of there will be one in the central zone, which is Seattle plus Vashon Island, one in the north zone, one in the east, and one in the south. And then the youth center will be sited somewhere in King County. It's not specified where. This is meant to help distribute where the centers are located geographically. It's not a barrier for where people are able to be seen. Anybody from King County, or even frankly outside of King County, are going to be able to be seen at any of these crisis care center locations. In terms of timeline for when this is going to happen, so I mentioned the implementation plan is currently before council and we're waiting on their approval. But as soon as they do approve the implementation plan, we'll then initiate a procurement for the crisis care centers. These centers will not be operated directly by King County. These will go to behavioral health operators who are themselves, so behavioral agencies who are going to be the ones who actually provide the clinical services and are also responsible for the capital development of the centers. And so we're going to open a first round this year and then have additional rounds to make sure that all of these get procured and awarded. Our anticipated timeline is that the first one would open at 2026 at the latest. That's assuming new construction and is really a very conservative estimate. We're certainly exploring all options to expedite that timeline. And you can see here that over the ensuing years, by 2030, we'll have all 5 of the crisis care centers open and operating. This is a bit more detail about residential, which I am gonna skip through in the interest of time, but just to say that there is a important focus here on expanding the residential treatment continuum, especially as a potential for people exiting a crisis care center. Workforce, as we've all again acknowledged, is a major issue, and so the investments in this space are focusing on strengthening the overall behavioral health workforce through training and recruiting, addressing things like tuition and professional fees, promoting the well-being of workers, and also increasing the representativeness of the workforce as a main issue. Also ensuring worker voice and career advancement. And so that means programs like apprenticeship programs and labor management partnership trainings. And then also specifically building a crisis workforce, because we got to staff all these crisis care centers. So recruiting and retaining for those settings, as well as offering specialty crisis care trainings. I mentioned early investments. It is potentially years off until many of these crisis care centers are built, but these crises are happening today. And so we need to take action in 2024 while that other work is ongoing. And so we also included funding to fund an expansion of community-based crisis response, and that includes mobile crisis for adults and youth, as well as program model that embeds behavioral health counselors into 911 to divert calls from law enforcement to instead get a behavioral health specialty response. Reducing fatal overdoses is a major focus. And then we have early investments that will focus specifically on residential treatment as well as workforce expansion. These are my last couple slides. Equity, I don't want to give this short shrift because it was so important in our community engagement process, and also is a strong framework throughout the entire implementation plan. There were 4 main areas that we really heard from that we worked hard to reflect in the actual strategies and activities of how we're spending the dollars of the levy. Those 4 areas were increasing access to care for populations that experience behavioral health inequities. And we have a significant description of which of those populations would be included there in the background section for the plan. Increasing access to culturally and linguistically appropriate services, again, increasing the representativeness of the workforce, and also implementing accountability mechanisms. Much of this aligns with what Mark left off on as next steps. We have the funding, we have a lot of this political will, we have a mechanism in place, but we also have to hold ourselves accountable. And so that will mean ongoing community engagement activities, as well as a robust performance and measurement plan where we have some principles that I've described here. But as a closing note, I do just want to make a pitch that this is an incredible opportunity. There is no other county or locality in the country that has made such a substantial investment in crisis facilities. And so it's an opportunity for research to understand how this is going to go, how these best practice models are actually going to play out in terms of serving the need. And it's really an opportunity to expand the evidence base for this type of crisis service. And so we'll be looking to academic partners and colleagues to work with us and collaborate on how to actually research and better characterize the effectiveness of these types of programs. So with that, there are many ways to engage. Happy to share additional information with anyone who's interested. This is just a summary slide of crisis resources that are available in county, which we often share during public presentations and might be of interest to folks on this call as well, as just like a summary of resources. And with that, thank you. I might leave this slide up if people want to take a picture of it or capture it more during our last few minutes for any questions.
Well, thank you, Dr. Goldman, and thank you, Dr. Snowden. I will say, just as a quick note, some of my favorite grand rounds are when somebody says, I'd like to establish a research collaboration, and then that happens during the grand round. So if anybody is inspired by that and wants to make a comment or question, you can do that now. We have a few minutes. And we do have a few minutes for questions. And very interesting to hear about statewide efforts and county and the distinction and the sort of complementary aspects of both. Very informative presentation. So I do want to encourage anyone to write in any questions. And as that's coming in, I want to say, I mean, one thing I think you both had talked about was sort of integrated care concepts, moving 988 call staff into 911 settings, sort of co-location in that way, general medical care and crisis centers. It's interesting to see some of those sort of common clinical scenarios come out in this crisis response clinical service as well. I wonder if you have other comments or reflections on that.
Mark, do you want to take that, or should I chime in?
You could start. I saw a text question that I was actually answering, but
Okay.
you go ahead.
Yeah, I mean, it's a great point, and it's very much in focus. I think a lot of folks who are trying to access crisis services have a lot else going on, and I hesitate to call it a one-stop shop, but we really do want to be able to consolidate resources in a single space to make these places more low threshold. It also helps to integrate social resources, so social services like access to housing and other types of social services. I think that can even be a carrot in a way to encourage people to come to a crisis care center if they have a mental health or substance need, but also have a housing related need. They might be able to get connected to multiple resources at once. So it's just the idea of wanting to make these accessible and desirable and actually meeting people's needs, given the range of of needs that people often have.
Thank you. And here we are with just a moment, and I see that I can see this in the Q&A, you're both actively typing. Do you want to just say out loud how much training a crisis care worker needs, or what type of training? Or
Yeah, that might be easier to do. So there's multiple types of workers at a crisis care center. So broadly speaking, the team includes 5 roles. There's a physician / psychiatric provider. There's nursing. There's mental health providers, so social worker or licensed clinicians. And then there's peer specialists, who are a really important part of the model. And then behavioral health technicians, which are more like BA agency accredited staff who help, maintain the milieu and support folks who are in the environment. There might also be substance use disorder professionals who are there to help folks with substance use related needs. And others, potentially could be there as well. But those are sort of the main components. So each of those will have different training needs.
Thank you. I know we're just pushing 1 o'clock here, but Mark, do you want to comment on where the calls are directed in King County?
Yeah, again, they go to Crisis Connections. The King County Regional Crisis Line, I think, is the same as what I'm referring to as Crisis Connections. That's who operates the line. And again, if for some reason they were not available, there's now a backup. But Crisis Connections answers all the calls here for King County. And there are a few places in the state where you can still use a 7-digit number that gets a more local line. But here in King County, they would still all go to Crisis Connections.
Great. Well, we're just past 1 o'clock here, and I imagine people have other ideas, questions, but we should stop for today. And it's I think you both spoke about future directions, next steps, ideas, and I would encourage any people who are interested in that to reach out to both of you. And yeah, I also learned beforehand there's other information that you may be able to present about in the future. So perhaps considering an update sometime down the road. But I do want to thank you both for putting together this joint presentation today. Thank you.
Thank you.
Thanks so much. Appreciate being here.
All right. Well, we'll end Grand Rounds there for today. So thank you.